What's going on, everyone? Hold on, let me adjust this. All right. What's going on, everyone? This is episode number 279.
Yes.
Okay, 279. We just did 278. I'm not going to lie. We decided to do 2 episodes in a row. So we're wearing the same clothes. If you're watching this on video, same clothes. But we decided instead of doing this on a Facebook Live, we do another podcast episode because it's probably noteworthy. We're going to talk about a recent member that just joined that does predominantly personal injury, had some PI questions with functional movement and systems, figured we would go through a podcast to be helpful for all.
Yeah.
So with that said, we're going to get started on that. So stay tuned. Here's what so many chiropractors have been searching for. How can we expand our clinical reach by finally addressing more than just the segmental component with our patients, but at the same time, not feel like we are selling out our chiropractic principles? The reality is our patients count on us to guide them. And when it comes to results, we must also address their posture and their movement. The verdict is out. Patients have spoken, and this is what they want and what they need, focusing on functional movement and corrective exercise. So how do we practice in a way where our community is engaged, excited, and seeking us out because of this comprehensive, results-based approach? That's the goal we've all been searching for, and this podcast will show you how. My name is Dr. Todd Pickman, and welcome to the MoveNow Chiropractor. All right, we are rocking and rolling. Okay, so here we go. So we have an email that we were sent from this doctor. Danny's going to read the email question. So this is like our viewers wrote in, and here's the question that they have.
Yeah.
All right. So what's the question?
Okay. So it says a large percentage of my injury patients would struggle even with completing the screenings and assessments. I see a lot of acute disc herniations, concussions, shoulder tears, knee tears, etc. I want to get these patients moving, but I'm not sure where they fit into the protocols.
Cool. All right, great. So essentially, PI. How does MoveNow fit into PI? It fits in perfect. It's perfect because when you're seeing injury patients need functional rehab. They need some level of curve correction, which we touch on. That's we really recommend people learn and understand chiropractic biophysics. That is the industry standard in that. We're not teaching CBP by any means. We direct a lot of people to CBP seminars. We help, figure out how to fit it together once they're exposed to it and they learn it. But curve correction, functional movement fits and is needed with injury work. Now, how do you do this when someone's acute is the question. They come in, they're so acute, they can't do a movement assessment. I have a couple ways of answering that. One is we typically do a movement assessment on day 2. If someone is so acute that they can barely even function, we're not going to do the movement assessment because we know everything's going to fail, right? However, it doesn't hurt sometimes, as long as you're not going to injure the patient, to go through the movement assessment and have the person say, I don't feel comfortable doing these pieces, cannot complete, and document it. And why do you want to document this in injury work? Because you want to show how dysfunctional the person was from the beginning, so you have comparative findings, you have functional outcomes, not just a form that they fill out, but could they even go through, 7 basic human movement patterns that we should all be able to complete? And if they can't, why can't they? Is it because it was all painful? They're apprehensive? What could they do? Now, that's one way of looking at it. In some cases, when someone is super acute and we feel like we're going to injure them by going through a movement assessment, we hold off. Yeah. And we spend the first couple of days doing really acute care, trying to get them out of, reactive muscle spasm and severe swelling and pain. And so there's other things that we'll do, like we adjust them, ice, electrical stimulation, which we literally just pulled that out of the closet like a couple weeks ago. Yeah. We have not used that routinely, but works pretty nice. A lot of people like it. We have a massage therapist that does quite a bit with deep tissue massage, and he can do some softer stuff too, although he's really built to do like extremely deep tissue stuff, which you're not going to do in the really acute situation. So my answer for you, doctor, and for everyone else out there, is what you do according to the science of functional movement is when you take someone through a movement assessment, if you choose to do so, even if most of the stuff's dysfunctional and painful and they can't complete it, or they say, I don't feel comfortable doing that, it's going to hurt me. Okay, great. Let's not make you do it. Is you're looking for patterns that they can do that are non-painful. So here's what I'll say. You take them through a bunch of movements. And for those of you familiar with movement assessment, this will be bare bones basics. For those of you that are not familiar with it, this is new information. When you go through a movement, you have 3 options. It's either functional, it's non-functional, 4 options, painful or non-painful. So it could be functional, non-painful. No problem. Great. There's nothing to see here. There's nothing to do, right? So they go through a cervical pattern. They can get all the range of motion. There's no compensation. They're not shrugging their shoulders. They're not grimacing. They're not doing all these things that we're taught to look at. And they're within normal limits. They're functional, painful, no worries. We're not dealing with that from a functional movement standpoint. Doesn't mean they don't have an abnormal cervical curve and we have to do curve correction. Doesn't mean they have segmental, it doesn't mean they don't have segmental subluxation. We have to go in and adjust them, of course. But from a functional movement standpoint, check, they're clear. Let's say someone goes through a movement and they can do it, but it hurts. That's functional, painful. Technically, you're not supposed to go through and be working functional, painful, any kind of painful pattern. And what you're taught to do in functional movement science is look for other movement patterns that are dysfunctional, but non-painful. So let's say they go through range of motion stuff with their neck, doesn't hurt, but they just can't complete it. But they're like, yeah, it doesn't really hurt. It doesn't cause me severe pain. Yeah, it's stiff, it's tight, but it's not, searing, stabbing, shooting pain. Side note, you have to differentiate between what hurt is, because some people say everything hurts if it's a little bit tight. That doesn't mean hurt. That just means it's a little bit tight. So if it is dysfunctional, like they don't get the full range of motion or they compensate, but they don't have pain, you can start working that from a functional movement standpoint, even in someone that's acute in maybe many other parts of their body. And the cool part is, like, let's say someone in the same scenario is, well, I'll flip the scenario around a little bit to something that's more realistic. Let's say someone is acute and painful in their neck, but their thoracic spine, when you do thoracic mobility, like extension and rotation in the thoracic spine, let's say there's no pain, but it's very dysfunctional. And you can start taking them through corrective exercises for their thoracic spine, and you can do so without hurting their neck. You will make their neck more functional by working that neighbor next door, which is thoracic mobility, right next to that dysfunctional, painful neck. So I would say you go in, you identify what patterns are non-painful, dysfunctional. You work those first. If everything's dysfunctional and painful, or functional and painful, you're not doing functional movement yet. Instead, you're going to work on things to decrease pain. Now, we have this warm-up sequence 1, 2, and 3. It's part of our protocol. Sequence 1 is cervical. Sequence 2 is thoracic. Sequence 3 is lumbopelvic. Those are primarily mobility techniques where you go through and you do global mobility first, which is like a foam roller. And some people can do that and it's uncomfortable, but it's not causing like sharp stabbing, searing pain. They can tolerate it and they feel a little bit looser afterwards. Then they can do focused mobility, like maybe double a cross ball into trigger points in the traps and J-cane. Then after mobility, then what you're going to do is you're going to go through extensibility. So like now you're going to try to take them through a little bit of a stretch. Now that you've calmed down some of the trigger points and the taut and restricted tissue, now you're going to try to actually get some range of motion and some stretch through the tissue, right? Just on a side note, a lot of protocols have someone stretching from step 1. That's not the best way to do it. You want to use mobility tools first. So side note, behind me, I have MoveNow Home Mobility Kit. All of our patients get home mobility kits. PI cases, they're all getting home mobility kits, and it's billable to the insurance as well. And we have letters and examples of how to charge for it and how to explain the relevance of it. But anyone that comes in that's injured is going to benefit from protocols within this mobility kit. Almost anyone and everyone. Okay. So you do mobility, so global, and then pinpoint mobility or target. And then you're going to do extensibility, which is a fancy word for stretching. And then you're going to do the motor control aspect. So you're going to repattern the movement. You're going to make sure the person's getting from point A to point B in a proper fashion, in a coordinated fashion. Like the muscles that are supposed to stabilize. The ones that are supposed to allow mobility and freedom of movement are doing so, and it's happening in a cohesive manner. The brain's working, basically. Motor control, major thing. Anyone that's had pain for a long period of time has a motor control issue. Anyone that's had pain for a small amount of time will start to have a motor control issue, and a lot of times you have to address it to free up their body. And then the last part is loading. We load now the pattern. We reinforce good movement with some strength. So let's say a forward bending motion, someone can't bend over and touch their toes. The loading version of that, I'll quiz Danny real quick. What's the loading version that would, like a loaded hip hinge?
So it's not a squat.
Right.
But it is.
Starts with a D.
Deadlift.
There you go. Good. So, and mind you, Danny's been to a lot of these seminars and been through all of this, and she knows this stuff, but her expertise, systems, communication, all the behind the scenes stuff. So I just threw it out there to quiz her a little bit right now. She's like, why are you doing this to me? But deadlift. Yeah. So deadlift is a loaded weighted hip hinge. And that's an important thing that we teach our patients that come in, maybe acute on day 1, week 2 through 4, but that's what they're moving towards. And we explain this to them and they understand the goal and the light at the end of the tunnel as far as what they're getting to. We're not just trying to get them out of pain. We're not just trying to just have them do, 1980s boring physical therapy movements. Like we're using kettlebells. We're getting into loaded movements. We're getting them functional and strong. Okay. Now, some of the other questions he was talking about, like shoulder tears and things specifically like that too.
Mm-hmm. Yeah.
So similar answer is you're looking to see, okay, if their shoulder is super dysfunctional, what's their scapular motion? Is their scapula dysfunctional but non-painful? Can we do some scapular protocols without taking off the glenohumeral joint? Can we do some thoracic protocols without, making the shoulder itself upset? Because another rule in functional movement is that anytime there's a shoulder issue, you want to address and correct thoracic mobility before you even look at the shoulder. So doctor who wrote in, recent member who joined, thrilled to have you, glad that you're doing this. It's awesome. Your patients are going to absolutely appreciate you and love it. You're going to have a great time with this, seeing injury patients and being able to do a more in-depth job with them. As you get further into the material, this will make more and more sense. But it's a good, fair question to start with, because it's something where, like a lot of chiropractors are just used to seeing a majority of their new patients are super acute. And they feel like they're so frail and they have to just walk on eggshells with them. And in some cases, when someone's super acute, yeah, you're not going to be doing a ton of stuff with them. But like someone with low back pain, do they know how to breathe properly? Like breathing's a functional movement. Mm-hmm. It's actually on day 4. There's 3 main things that we teach a patient movement-wise. I'm going to quiz Danny again.
Oh boy, put me on the spot. So it's hip hinge, proper breathing, core.
There you go. She got it. Okay. And in front of our YouTube video, you can see I gave her a hint, but she had this. So breathing, hip hinge, core is on day 4. Day 4 is when we onboard someone to functional movement. We get them their home mobility kit, their home traction setup, like whatever's applicable for them. We teach them breathing, hip hinge, core. We expose them to the 12-week transformation. Oh yeah, look at that. I have it right behind me on the shelf. So 12-week transformation, they get their journal, which this is the journal for the 12-week transformation. So if you're watching this, you can see I'm holding this journal that we bind and we give out to our patients so that they have tons of resources so they can follow along. So again, if they're super acute, you just meet them where they're at. You figure out how to decrease the pain a little bit more. I'll give you an example for like acute neck issues. And I just finished a series on this, which we're going to talk more about here soon, for public education on injury, spinal ligament injury and personal injury. It's called The Dirty Little Secret of the Car Crash Industry. It's talking about how attorneys, insurance adjusters, and doctors oftentimes are not doing things as well as they could, whether knowingly or unknowingly. And the patient suffers, unfortunately, as far as for benefits and care that they're rightfully entitled to and avoiding lifelong injuries. Where I'm going with that is in the injury world. Ideally, you get bending x-rays, flexion extension of the neck to rule out instabilities. But the majority of the time when there's a cervical instability in like upper, mid, lower neck, not talking about atlas, but C2 and down, the majority of the time the instability is the bone actually translates or has excessive rotation, so flexion extension in extension. So when they go in extension, the bone misaligns posterior, it slides too far posteriorly. So the traction, which is really nice about curve correction traction, we're pulling the segment from P to A, from back to front. And so a lot of these patients need traction. They're candidates for traction. The MoveNow neck traction unit, which is it's a neck traction unit that's as close to in-office two-way traction that you can possibly do, which is a chiropractic biophysics thing. We made our version of home care a little bit more aggressive than just laying on a foam block for the neck. But it's also not just more aggressive, you can make it less aggressive. So you can actually dial it down if someone's super acute. And a lot of times in the neck, and a lot of the auto people have neck issues, right? Like their neck is one of their main things that they're injuring. Putting a little bit of extension and a P to A force specifically where there's instability or where there's posteriority of that segment gives a ton of relief, helps with range of motion, helps to just heal things positionally, disc-wise. So teaching the person, like you can lay face up at home and you can put this under your neck at C6, angle it 5 degrees up, put a little bit of a load pulling forward and just lay on the ground passively and relax and breathe through it. And then there's a safe way for them to get out of it and they ice afterwards. And that's part of their acute rehab. So to answer your question, like discs, especially cervical spine, we have a solution for it. And as the person gets better, it goes more aggressively. There you go. All right. We'll have to reach out to this doctor and let him know we did a podcast episode just for him.
Yeah.
Okay, cool. All right. Dr. Brian G., this one's dedicated to you. All right, cool. Anything else to add on this one? I know this is more of a clinical one, but I think we answered.
No, I don't think so. This was helpful for me. So that way, when this question does come up with members, I can answer it from your perspective.
Awesome. Let's do more podcasts like this.
Yeah, thank you.
Cool. It's like a training / podcast all in one. All right, cool. Awesome. All right. Well, next one, you can teach me how to make cupcakes.
Oh yeah.
Because she's got a bunch of kids that makes cupcakes and cakes for all their birthdays. And I was blown away because at the birthday that we just went to, 2 weeks ago, you had all these cupcakes that I thought for sure you had bought from some fancy bakery. And I'm like, where'd you get these from? And you're like, I made them.
Yep, I made them.
Yeah, awesome. All right. Well, with that said, we'll go on the outro here. Make sure you check out these links. You can get a free book, which is Move Well Secrets, before we change it to Move Now. There's a story behind that, but not going to go through that right now. But Move Well Secrets. And then you can watch our 30-minute demo.movenowyou.com. Listen after this. You can find the link to get the book. We'll send the book out to you for free. It's a cool little quick read. Gives you a good overview of how this whole thing works as well. So, all right. See you next time. Subscribe on YouTube as well, Move Now University, and subscribe to the podcast wherever you listen to podcasts. Want more Move Now secrets? If so, then go get your copy of my best-selling book and watch my 30-minute behind-the-scenes Move Now demo. My book is called Move Well Secrets, and you can get your free copy at book.movenowyou.com. And watch the 30-minute demo of our exclusive doctor training portal at demo.movenowyou.com. With these two resources, you'll find my top 22 secrets that we've used to build one of the smoothest running, results producing, and super profitable exercise departments within a chiropractic clinic in the entire profession.